Happy New Year, everyone. As we head into 2019, at Regions EMS, we're excited about where this year could go. There are a lot of really cool things happening in the Twin Cities related to emergency care, and we've got some interesting ideas about things like EMS education, quality improvement, research, and some new technology that's coming out. We want to equip you with the best tools to provide the best possible care to every patient. That's a big reason why we produce these videos. It gives us a chance to give you the latest and greatest information as it becomes available, rather than waiting for it to trickle down through CME and critical case reviews. One of the ways we accomplish this is by attending regional and national EMS conferences to see what ideas and research other agencies are doing, as well as share some of the discoveries that you have been a part of right here in the Twin Cities. We recently sent a team from our office to Austin, Texas for the 2019 National Association of EMS Physicians annual meeting. This is a conference that I look forward to every year, as there is always some very interesting and exciting research that we get to hear about. This month, we're going to scale back our production a bit and bring home some of what we got to see and hear about in Austin. We were able to interview several presenters during the research poster sessions and learn more about the successes, challenges, and innovations from their agencies. Some of this information is new, some proves what we already thought we knew, and some simply shows us that what we are doing here in the Twin Cities is in line with the rest of the country, and in some cases, we are even several years ahead. Hopefully you'll learn something new today. So let's take a little trip to Austin, Texas. Check this out.
My goals for this week are obviously reconnecting with old friends, making some new ones, learning great new science, and seeing what we can do to improve out-of-hospital care.
Yeah, I think that's the goal for all of us, right? To get together 1 week a year and improve our own systems back home.
Paramedics need to know that just because it's NAEMSP does not mean you need to be a physician, right? So I'm a professional member. I'm super excited to be here.
And I think that those that are here in attendance will be very pleasantly surprised by the diversity of offering, from research to position papers to everything in between. So I think it's going to be a great week, but the number one goal is the success of the organization in the long term, and I know we're going in capable hands with Dr. Tate.
All right, guys, I got an interesting one for you here. This ties the zombie apocalypse into EMS. I'm going to hand the microphone over to Dr. Haas here, and he's going to tell us all about it.
Hey, I'm Tyler Haas. Back in my home institution, back at University Hospitals, one of the things that people don't have a lot of enthusiasm for is disaster drills. And so me and Dr. Pound, in our Genius discussion, figured that what it was missing was zombies, and that's what would really, pique everyone's interest. So we kind of set out and tried to set a survey and kind of mask it in there and say, what makes you interested, what makes you not interested in, and try to sleep in the zombies in there and see if people would actually boost interest and boost some of the participation in some of the disaster drills. Sadly, it's a negative study. So, as it turns out, one of the largest noises we got out of this study, we did a lot of Likert charts and things like that, was that people would not be interested in a zombie apocalypse disaster drill. So, if you are feeling creative, don't. It turns out that you should do the drills that people are most likely to run into, and that's what they're really interested in, is what are they most likely to run into. And that was kind of the big conclusion that we ended up coming through after sifting through all the data was, nope, zombies is not what it was missing. We need to just do what they're going to run into. So,
Hey, Dr. Haas, that sounds great. I do got one follow-up question for you. You know, if this event does occur, do you recommend Haldol or benzos for the zombies?
I would say benzos, definitely.
There you have it, guys. Straight from the boss. Benzos for zombies. All right, guys, I'm here with future Dr. Cole, and we're going to talk a little bit about stroke. You know that the stroke guidelines have changed a lot recently. We're now treating people out to 24 hours. But one of the big questions is, do they have a type of clot in one of the large blood vessels, which requires a very specialized treatment? So I'm going to pass it over to future Dr. Cole and tell us about your research.
Sure. Yeah, so as he just said, large vessel occlusion strokes are better treated with endovascular therapy. However, most hospitals, or not most hospitals, but some hospitals do not have the equipment to be able to handle that. So what we want to do is be able to identify patients who do have large vessel occlusions in the triage setting so that we're able to send them to the correct hospitals and therefore cut down on transit time. So what we specifically looked at is a Cincinnati Stroke Triage Assessment Tool, because in Northeast Indiana, the area that I was looking at, that is a new scale that EMS is using. So we wanted to look and see how effective that is, and then evaluate how it compares to other scales, including the NIH-SS or the NIH Stroke Scale, and a combination of the two in looking at LVO stroke. So basically what we found was that CSAT is pretty on par with other stroke scales. We got a sensitivity of about 58% and a specificity at about 80%. So it was pretty good at predicting who did not have an LVO stroke, but I think we'd like to get the sensitivity a little higher. So that what we then did was we noticed that the mean NIH-SS scores were found to be statistically significant. So we wanted to go into that and look at it a little bit more. We also found that LVO patients had more NIH-SS scores of 16 or higher compared to non-LVO stroke patients. But when we looked at that with CSAT, there really wasn't that much of a difference. So we were wondering, since CSAT is kind of just an abbreviated version of NIH-SS, we wondered if maybe we're just pulling not all of the correct subsets of that scale, and if we should pull out some other categories, make different combinations, and see if we can find a better scale in the end. So that's kind of where our research is headed in the future. We've played around with that a little bit, managed to get the sensitivity up a little bit, but also lost some specificity. So we're going to continue to work with that and see what we can do there. So.
Well, Anna, that sounds great. So as you guys know, we use the Cincinnati Stroke Scale now, but there's a lot of them out there. This is cutting edge stuff. We're keeping on top of the changes in the literature, and we'll let you know if we need to adjust the guidelines. All right, guys, well, now we're going to talk a little bit about transfers of care. We know that's a high-risk situation where information can be lost. And in EMS, you receive a transfer of care from the nursing facility, and you give one off to the hospital. So I'm going to pass the microphone over here, and we're going to hear about the cutting-edge stuff on transfers of care.
Hi, my name is Akash. I'm actually a third-year medical student at Penn State. So I did my research on the transfer of care from EMS to the emergency department. And kind of like was said, it's a fragile time in healthcare. A lot of moving parts. So in Pennsylvania, at least, there is a transfer of care form that's handed off in the emergency department to the ED staff. And then within 72 hours, they're required to file a patient care report. And so my hypothesis and kind of what I was looking at was, do those two forms line up? Does the paper form and what's filed online kind of line up? So I looked at a couple key data points, including the chief complaints, medications, allergies, kind of some basic stuff, and then some more real-time information, including the vitals, the GCS, any care that was provided in the field, and was just looking to see if that information lined up. So I took 200 charts in a 1-month period, and I kind of compared the information. And I found that, you know, looking at some of the basic stuff like the chief complaints, allergies, meds, it lined up to some extent, but the chief complaint only 72% of the time lined up. Allergies, 82% of the time. Medication, 66% of the time. But then you look at some of the more real-time information, like the vitals, forgetting whether they even line up or not, looking at whether the data was there. So within the two forms, there's 3 spots available for blood pressures, but 3 blood pressures might not have been there in some of the forms. So it was only available in 68% of the online forms and 30% of the paper handouts. And then some of the other data, like the blood pressures, lined up. There was substantial correlation, but might have not been exactly the same numbers. And then with the respiration rates, GCS, that kind of stuff, there was poor correlation between the data. So what does this mean? At least for me, it means, well, at least I can say that there were significant differences between the information. And then there's definitely room to kind of further evaluate this process, kind of acknowledging that this research doesn't look at the verbal handoff and a lot of the information that's handed off there. At least the documentation and that process has some room for improving and streamlining that, maybe through making this entirely electronic or other possible ways. So, thanks.
Hi, I'm Joe Holly. Did part of this study here. So what we looked at was an attempt to compare a series of supraglottic airways to the gold standard endotracheal intubation in their ability to form a vacuum in the chest, negative pressure in the chest, with the use of the ITD. So we used a cadaver model that was instrumented that allowed us to measure airway pressures as well as carotid pressures as well, which we'll talk about in a minute. And we utilized these multiple different supraglottic airways in a random fashion in each cadaver, while we did a multitude of different versions of CPRs. By that I mean we did manual CPR, manual with the ITD, mechanical CPR, mechanical with the ITD, active compression, decompression CPR, head up CPR, etc. We did lots of different versions. Part of what we were looking at was are these supraglottic airways as good as an ET tube in their ability to maintain that vacuum? In other words, the ITD will not work unless it can generate a vacuum. So we wanted to know, were there differences between those? The thought being, we've seen many services that have implemented the ITD and not seen significant changes in their ROSC rate and have then abandoned the use of the ITD. And my concern is they replaced the wrong part, right? The ITD does exactly what it's supposed to do. The difference was they were using a supraglottic airway that was not allowing a seal to form, and therefore they couldn't form a vacuum. So what we saw here is that LMA, AirQ, and iGel were able to generate vacuums in the airway nearly consistent within the tracheal tube. King and CombiTube were extremely inconsistent in their ability to generate a vacuum. That says a couple of things to me. One is that not all supraglottic airways are the same, and that supraglottic airways are not equivalent to endotracheal intubation in the ability to generate negative intrathoracic pressure to take advantage of the life-saving benefits that the ITD has shown. So I think the take-home message here is, if your system is utilizing an ITD that doesn't do a very good job in making a seal, before you abandon the concept of intrathoracic pressure regulation in the ITD, you should really take a look at your supraglottic airway, because that may be the reason that the ITD is not doing what you think it should be doing.
I do have one question for you. We talk a lot about managing airways with BLS techniques, at least initially, while we get shocks on board and everything else, but we emphasize using the ITD and the rescue pump right off the bat as well, because we know of the survival benefit. Did you compare any of these devices to just bag valve mask with an ITD to get airway pressures with that?
We did not. So this was all about the specific focus on the supraglottic airways. So we did not throw in the mix the bag valve mask itself. I think as long as that seal is intact with the bag valve mask, the concept should work equally well, but I don't have numbers to back that up.
Thank you. The other thing's interesting, we're talking about airway devices, but we're really not focusing on their ability to deliver ventilations. We're focusing on their ability to help you deliver blood back to the heart. So while we're talking about an airway device, we're really, in the end, talking about blood flow. So thank you, Joe. It's a great research.
Thank you very much.
Thank you. All right, guys, here we are with Jeff Jarvis from Texas. We're going to look at an interesting poster that deals with pediatric airway management. Dr. Jarvis.
Thank you very much. Hi, guys. My name is Jeff Jarvis. I'm the EMS Medical Director for Williamson County EMS, and I'm an emergency physician in the Round Rock area for Baylor Scott & White. I have a fascination with airway management with EMS, And like y'all, my EMS system no longer intubates children. We are very aggressive about intubating adults, but we use an iGel only approach for our children. And I wanted to take a look at using national data. How well do paramedics across the nation with a large data set perform with endotracheal intubation, comparing adults to children? And then I also wanted to do that with supraglottic airways. So what we did is we used ESO data, a large EPCR company. We used blinded data from 2017. We ended up with around 700 different agencies who had performed at least one advanced airway attempt on children and adults. And our primary analysis was to look at the first pass success rate with endotracheal intubation, as well as the first pass success rate with supraglottic airways. And what we found is the vast majority of advanced airway management was with endotracheal intubation, and it was with adults. Over 28,000 of these were in adults, only 523 were in children. If you can kind of look at our poster here and get a rough idea of the distribution. But ultimately what we were interested in was first pass success. And we found first pass success with an endotracheal tube in adults was 73%. Versus children, it was 59%, and that was a statistically significant difference. You can just look at this and see that it's a huge difference. Now, the interesting thing is if you compare 73% first pass success with intubation in adults to 59% with children, with intubation, well, how does that differ with supraglottic airways? And it's 89% versus 84%. That is not statistically significant. So when you look at adults versus children, success rate is clearly different and is worse with children using endotracheal intubation. There's no difference when using supraglottic airways. Now, we also wanted to look just at children and break them up into smaller groups and see whether the same thing held. And you can see this here where we have our age groups in children, under 1, 1 to 6, 6 to 10, and 10 to 14, as well as over 14, so our adult population. And you see with endotracheal intubation, the first pass success continued to climb with age. So the older you were, the higher your odds of first pass success, and conversely, the younger you were, the harder it was to achieve with intubation. And again, with supraglottic airways, that did not exist. So what we found is that doing any type of advanced airway management in children is rare, and we are really bad at doing it in children. So my takeaway, my personal takeaway, is that my system is justified in using an iGel first approach for our pediatric patients because we don't see them very often. It's very rare, and we're quite honestly not very good at it. And again, that's coming from a system that's very aggressive about endotracheal intubation.
So that's all we've got time for this month. One thing I learned about Austin that didn't make it into this video is that the entire city has been overtaken by scooters. We saw some interest last summer in the Twin Cities for scooter sharing services, so we'll see what this year brings. Could be really cool and convenient, or might bring us even more job security. It's not clear yet which way it will go. Anyways, thanks for watching. We'll be back with our normal format next month, so keep sending us ideas. Don't forget to follow us on social media for our latest news and videos, and make sure you have our mobile app to stay up to date with our guidelines. There will be a minor update coming out soon to correct a few typos, but nothing that will actually change any patient care. For everyone at Regions EMS, I'm Dr. Peterson. We'll see you next month, but until then, stay smart, stay safe, and stay professional.